CPR more than 50 minutes and no signs of life or asystole, then we should not go for ED phlebotomy. If we see about the cardiac trauma, penetrating trauma, most of it is on anterior-inferior wall and lateral wall. So these are the things which you have to look for in secondary survey, which are the potentially life-threatening injuries. I am not going into the details of that. Blunt cardiac injury, if there is severe blunt chest trauma, you should always suspect that patient may have blunt cardiac injury. So, how to recognize? There will be abnormal ECG and dysarrhythmias, okay? Then we have to immediately go for echocardiography. This is how, if there is a ventricular laceration, you can repair it. Different pictures of cardiac repair. So it's not so that you cannot go for surgery in these patients. This is a sub-xiphoid pericardial window. If you are doing, many times it happens, you are doing an laparotomy or something like that, a patient has gone in asystole during surgery, then you can go through sub-xiphoid window for doing open cardiac massage. So acute injury pattern will be there in ECG. There will be elevation of the ST segment, there could be depression in lead 2, lead 3, there could be bundle branch block, there could be atrial fibrillation. So these type of arrhythmias may be present. So rapid acceleration, deceleration injuries are there. If suppose, then that is why mechanism of injury is important. Then you have high degree of suspicion of aortic disruption. And you have to look for X-ray signs. Salvageable tear when hematoma is contained. जिसमें contained नहीं है, hematoma नहीं बना है, वो तो patient वहीं पे succumb कर जाएगा on the site of the scene. So 1/3 die within 24 hours without treatment if they are not reaching to the hospital. So widened mediastinum is a very unreliable sign. ऐसा नहीं है कि आप लोग you are taking X-ray in a supine position. Okay, that too AP view in most of the patients of trauma. Okay, so that is not a very reliable sign. So esophageal echography, helical contrast CT or MRI or aortogram has to be performed where you are suspecting aortic injury. So this is the helical CT angiography where you can diagnose so besides widened mediastinum, so sensitivity is only 53% and specificity is only 59%, but negative predictive value is 83%. Okay, that is why it is not a very reliable sign. So what has obliteration? There could be obliteration of the aortic knob, rightward deviation of the trachea, depression of the left main bronchus, elevation of the right main bronchus, pleural cap, left hemothorax, which can be also bilateral also, and fractures of the first or second or both the ribs. Cell कमजोर हुई क्या? Then diaphragmatic injury often missed in these patients. Okay, so you have to high degree of suspicion. It is more common on the left side because the right side is protected by the liver. Then a word about traumatic asphyxia result from sudden compression injury directly to the chest. Can cause massive rupture of the vessels and organs of the chest cavity. Ultimately, patient leads to death. These are the pictures showing traumatic marching sign. Okay. Then seashore sign is a normal and there is no pneumothorax. Then it is seashore sign. तो seashore में क्या दिख रहा है? Sky कैसा दिख रहा है? Skin subcutaneous tissue will look like sky, muscles will look like ocean, and beach will be lung sliding motion or sandy appearance. So it is seashore sign. अगर pneumothorax होगा तो कौन सा साइन मिलता है? बारकोड साइन. ठीक है. Lung point I am not going to discuss in detail about lung point, but so this is, there is no lung sliding. This is absent lung sliding. And this is the battering sign. You can see the upper rib, you can see the lower rib. So it is like a wings of bat. Again, there is no sliding. उसी की ये थी. This is the lung point which is said कि जहाँ पे आपका प्लूरा और लंग मिल करके हिल रहे हैं, that is lung point. ये बैटरिंग साइन का वो है. This is the seashore sign. Sky, ocean and beach, which is seen normally. This is the barcode sign. Okay, pneumothorax is present, you will see barcode sign. So mediastinal trauma, this is the management algorithm. I will not go into the details of mediastinal trauma. So occult injuries may be there, you have to suspect them and then you have to manage them. This is usually seen in tertiary survey, primary survey, secondary survey, and then tertiary survey, where we look for missed injuries or occult injuries. So the role of thoracoscopy and VATS in thoracic trauma, it has got good role, especially in patients of retained pneumothorax, okay, or in cases of suspicion of diaphragmatic hernia. So our last year experience is we have admitted blunt injury trauma chest patients around 1,174, penetrating injuries 286, total 1,460 patients of thoracic injuries were admitted, out of which only 21 thoracotomies were done. So I have already said 80% can be managed by chest tube drainage only. Then we have flail chest, 64 patients are admitted, and only in 16 patients where the intensivist asked, then you have to go for refixation from the refixation. Then we are also going streptokinase instillation in patients of retained hemothorax. Okay, so we take 2.5 lakhs units of streptokinase, dissolved in 50 to 100 ml of saline, instill inside the pleural cavity, clamp the tube for 3-4 hours, and keep changing the position of the patient for that 3-4 hours, and then we open the tube. The success rate is around 80 to 86%. These are the cases we have managed, few cases of impalement injuries to the thorax. These are the cases where we have done refixation and sternal fixation. This is the repair of the left atrium which we have done in our trauma center. So any queries? So समझ में आ गया? हैं? जब सवाल नहीं होते हैं तो इसका वही मतलब होता है तो कुछ समझ में नहीं आया है, सब कुछ सर के ऊपर से निकल गया या सब कुछ समझ में आ गया. क्यों बसंत जी? बसंत साहब का मैं स्वागत करता हूँ. He is a pediatric surgeon in SEP. So that to summarize, chest injuries are common in multiple in the patient. ABCD now, it is XABCD approach. Initial stabilization to simple maneuvers like airway control and tube thoracostomy. The goal of treating chest injuries is to establish normal gas exchange and normal hemodynamics. Thank you.
Thank you, Sandeep Tiwari sir, for explaining and talking in such a comprehensive and interactive manner. I would request Professor Vinod Jain sir for felicitating Professor Sandeep Tiwari sir. I would again request Professor Vinod Jain sir. He is an ex-professor from Department of General Surgery and he will be presenting his talk on abdominal and pelvic trauma.
वो देना, चेंजर देना, चेंजर ये हमारा बेटा रख लो, हाँ अपने पास रख लो, अच्छा ओके. So Professor Sandeep Tiwari has made my job very easy, and since we have been involved in ATLS and we have established center, you should be very proud of you that you have got a very good ATLS center. And before I begin, I appeal all of you, all the residents, surgical residents or person who are managing emergency and trauma or even not the critical care, they should take up the ATLS course, and then only they will find what it is and how important it is. So this part Sandeep Tiwari has explained to you very well. I am not going in detail. Now this is the case scenario. Huh? So this is unrestrained again car driver, which normally happens. सिंह साहब नमस्कार. नहीं आप आगे की सीट बैठे ना, वो सब हम आपको रेजिडेंट समझ रहे थे. So there are bruises in the anterior abdominal wall. Patient is confused. Heart rate is 130 per minute. Systolic blood pressure is 80. Respiratory rate is 30. Patient is looking pale and he moans on touching pelvis. He has got rotated right lower limb, but there is no obvious fracture. These all things have been told by the pre-hospital person who is bringing the patient to your hospital. Just think of your emergency. Think of yourself sitting in the ED and getting this information. And the treatment, whatever is being done, the patient is usually being transported by ambulance and the cleaner, a driver and cleaner, not paramedic, and some oxygen is put. That is a common scenario. Now my question to you is, what are your concerns? See, we have been in habit of interactive sessions, so I may be taking long, I do not know how long it goes. Hanji. So what are your concerns? You go for the scenario. Please tell your good name. Huh? Sarona, yes. What is your concern about this scenario? Suppose you receive this type of patient. Yeah, yes, huh? No, no, see, looking into the parameters and the symptoms and signs, what do you think? Patient is having airways compromised or not? Looks, huh? Why airways compromised? Achha, okay, patient is confused. One is actual compromise, one is threatened compromise. Threatened compromise. So airway, that means you have to take care. Again, the same principle. Breathing part. High, so breathing may be involved. You have to look upon whatever Sandeep Tiwari has told you just now, shortly trauma. Circulation part. Shock may have because of the tachycardia and systolic blood pressure low. And what about the head injury element could be there or not? Patient, okay. So these are your concerns that the A, B, C and D are involved. Now the thing is, what could be the possible injuries? And I think all of you, most of you have managed abdominal trauma, because the trauma, not only the trauma department, but usually in our time, you used to come to the surgery department. हाँ जी, क्या क्या इंजरी हो सकती है इसको? बेटा बात ना करो, टेली What else? Yes. What are the injuries? Okay, one is pelvic fracture. Abdominal injury, very good. अब ये अनरेस्ट्रेंट बैठा हुआ है, जाएगा उसके ऊपर तो क्या लगेगा? तो चेस्ट पे इंजरी हो सकती है क्या? हो सकती है कि नहीं हो सकती? हो सकती है, हेड इंजरी हो सकती है कि नहीं, हो सकती है. Means patient may be a case of polytrauma. So whenever you manage a patient, as Professor Sandeep Tiwari has told, you have to bother for the physiology first. You have to settle the vital first, and you should be concerned about the vital first before going on the definitive treatment. Now, how will you plan to manage during transit as a emergency officer, as a ED in charge? What do you think, how the patient should come to you? During transit means while the patient is coming into the ambulance. When you receive the patient, how should you do, what should you do? And when you discharge the patient, what should be done? So these three things we will be discussing in upcoming 10 to 15 minutes. Right. So under these headings we are going that we have to understand the anatomy. Anatomy, not the anatomy of the anatomy part, 9 hypochondrium and all. Anatomy from the perspective of trauma person. Then significance of the pelvic trauma, the overview, pre-hospital care, emergency department, all these one by one we will go through. So this is the anatomy. Since time is less, so I will not be having interactive session. All of you know, I will just for the sake of repetition in the trauma, you call anterior abdomen bounded by anterior axillary line, lower by the ligament, upper by, not diaphragm, by costal margin. You have the surface marking. Then you have got the flank between anterior and the posterior axillary line. Upper part is 6th intercostal space and lower part is iliac crest. The back becomes the tip of the scapulae line and lower part is your iliac crest and lateral is posterior axillary line. The flank I told you, and thoracoabdomen is your from the nipple up to the costal margin. So this is very important for you to understand. Why? Because suppose patient is having some sort of injury in the back or the flank. What organs are going to be damaged? You should consider. All intraperitoneal or retroperitoneal? Retroperitoneal, kidney, pancreas, duodenum, ascending colon, descending colon. And often these, whenever there is a retroperitoneal injury, then you are not able to judge by palpating the abdomen or by doing even e-fast, by doing the fast. Fast ki full form kya? Focus, very good. Focused assessment, because now the fast is basically your stethoscope. All the persons who are managing trauma or the emergency should learn fast. That is why I am telling this is important. So the significance, as you see, because mostly I know many cases, many elite person, even अमिताभ बच्चन का क्या हुआ था, कुली में क्या हुआ था, कुछ बता सकते? You know the story of अमिताभ बच्चन? हाँ? अमिताभ बच्चन में कुली क्या, जब शूटिंग हो रही थी तो उनको मेज का कोना लग गया and he was admitted to some primary hospital. Somehow it was not hemorrhage otherwise, but the things were missed and later on developed peritonitis. Then he was operated, the colonic injury was there, colostomy was done, I mean so many things. So that means if in the trauma, often it goes unrecognized till you see critically. That is very important. And moreover, in the abdominal contour, lot of blood is lost and you do not get any physical signs apart from the heart rate and the, in the abdominal signs basically, and that is very true for obese person. Then as Professor Tiwari has told you, that identifying the specific injury, this is liver trauma, the spleen trauma, renal trauma, correct the physiology first. So as a resident or as a trauma person, as a trauma physician or a surgeon, you should be and must do this, that you have to correct the physiology and you should know how to correct the physiology. And for that I insist that you should take up your ATLS course. That is why I am telling you, because that is a huge involvement. Overview. So this is basically leading cause of death. And in the pediatric age, it is second most common. After injury, the most common is, Shalinji Namaskar. In the head injury, is the most common in the pediatric age. After that becomes a abdominal trauma. Why? Because it is a pliable, abdominal trauma is pliable, and usually in the pediatric age, you do not get many of the signs. Mechanism could be blunt, penetrating, or the blast. For the blast injury, I tell you, very important, that you may not be getting good number of clinical signs abdominal, but because blast injury could happen in hollow viscous organ without obvious trauma externally. Correct? Some bomb blast is there, the pressure waves will go in and rupture the hollow viscous. So that is very important. The mechanism important. And in the blunt abdominal trauma, the mostly spleen, then followed by liver and small bowel. That is absolutely a percentage. You all know as a resident. Now, this is very important. The pre-hospital care. What do you expect? You expect that patient should be brought safely to you with oxygenation, with care of airway. At least your person who is bringing the patient. All the time residents will not go on the site. They will be trained paramedics. They should know how to clear up the airway, how to clean up the airway, how to do suction, how to give oxygen. And then number 2 is immobilization. That all the trauma patients should be immobilized by putting cervical collar and spine board. I think you must have not seen any patient being received with cervical collar or the spine board. As a ambassador of this trauma person, you should insist your government, your institution, that in all the ambulances which are being there should be a spine board. Because you do not know what is going to happen with the cervical spine, And that is very, pity space to know, and that you have to insist. You as a leader has to insist. Datsab in his institute has to insist upon. Now cervical collar, we forget to put cervical collar often many times. So that is very important, and you all desire for that. Then that person who is bringing should know how to stop bleeding, how to put a pelvic binder, especially in the abdominal trauma, because the limb is rotated. There is a large pelvis, lot of bleeding is going on from the retroperitoneal venous plexus. So he should know about applying the pelvic binder. Most of the residents, I am very sure, are not very well conversant because it is not available. Then stop bleeding means you have to do the pressure, then you have to apply the packing and or the tourniquet. They should be trained. So it is your duty, not even you should get trained, but you should train to your paramedics, and those paramedics or the ambulance driver or the fire persons or the, we keep on teaching, we keep on training those persons. So that is your duty also. And whenever you are giving fluid, it should be wide bore cannula, number 1. It should not be that 20 gauge IV or 22 gauge or even 18. It should be 16 gauge. And the fluid, especially in the winter season, should be warm. ठंडा दे देंगे तो क्या हो जाएगा बेटा? हाइपोथर्मिया से क्या हमको प्रॉब्लम क्या है? एक चीज होती है ट्रायड ऑफ डेथ, लीथल ट्रायड ऑफ डेथ. वो क्या है? हाइपोथर्मिया, एसिडोसिस, coagulopathy. So this is going to induce trauma-induced coagulopathy, and we have to prevent it. Then communication, when a person is coming, the person should keep communicating to you. So you should know, you should be prepared. Now in the ED, the patient has been received by you, you should be prepared. You do not know the status of the patient, you should take standard precautions, because many of the residents, they do not take standard precautions. They are not immunized against the hepatitis B, and they just out of their enthusiasm, they start touching the patient without even wearing gloves. What to talk about the aprons. And you have to identify and give early blood transfusion. Normally what we do, we start giving crystalloid. Okay, you are giving warm crystalloid. But it has been seen that if you start giving crystalloid and keep on giving crystalloid, again that is going to induce trauma-induced coagulopathy and going to increase the odd ratio of death, trauma mortality. So give blood as soon as possible. Platelet, plasma and RBC 1:1:1 as soon as available and possible. And then this is the new one, tranexamic acid. How many of you about giving it? This has become, yes, this has become standard protocol for all trauma patients to give tranexamic acid 1 gram as slow bolus over 10 minutes, followed by 1 gram over 8 years. This is again going to stop many of the, save many of your patients from mortality. And it should be given preferably within 1 hour of trauma. Normally we do not get, but yes, within 3 hours. Within 3 hours it has to be given. That is very important. Then secondary survey. Means you have to find out the anatomy, what injuries patient have got. And then suppose you as a resident are there and the patient is not responding or a transient responder. That means patient is bleeding somewhere from his spleen or liver. You have to at least go and open and do the damage control. Do packing, close the abdomen, बाद में देखा जाए. So you should know about that damage control surgery. And of course, in few of the solid organ, you go for non-operative management. You should be aware of that also. Basic aim is to save life. So inspect, auscultate, percuss, palpate. अब ये बताते हैं यहाँ कि pitfalls क्या होते हैं as a resident or the many of the persons who are treating the patients in their trauma. सबसे बड़ा pitfall ये आता है कि हम लोग log roll नहीं करते, बैक में नहीं करते, बैक नहीं देखते, फ्रंट देखते हैं, बैक में पेशेंट को इंजरी है, पेशेंट में भी ब्लीडिंग फ्रॉम बैक. सो एंड व्हेन यू आर सीइंग द बैक, ऐसे नहीं पलट देना है, उसको लॉग रोल का एक प्रिंसिपल होता है दैट यू नीड टू फॉलो. देन एग्जामिनेशन ऑफ पेरिनियम एंड यूरेथ्रा ऑफन वी फॉरगेट. देन वी ऑफन डू नॉट डू पीआर एंड पीवी. उसमें ही हमको मालूम चलता है कि ब्लड है कि नहीं है, वट एवर द बोनी प्रोमिनेंसेज है कि नहीं है, फ्रैक्चर पेल्विस है कि नहीं है. वी डू नॉट डू पीआर एंड पीवी वेरी ऑफन in trauma patient. The pelvic compression test. JR1 has come, has done the pelvic compression test once. Then JR2 has come, then JR3 has come, then the consultant has come, Dr. Vaibhav has come. See what is happening every time you are touching. So it has to be done once by the most senior person. Pelvic compression test and should be noted. It should not be repeated. Then we often in emergency do not take care of exposure. We expose the patient, especially in the winter season. Again, the patient is prone for hypothermia and we induce trauma. And then number 2, as I told you, we keep on giving crystalloid, and that is again going to increase the trauma-induced coagulopathy. And then we have seen in our practice during our this thing, even in my residentship also in this institution, I have done my MS in 1984. So, sending patient to CT scan without stabilizing, that is basically a crime. You should not do, please do not do. First of all, manage the patient, stabilize the patient, do X-ray, chest or pelvis bedside, do E-fast, but do not send the patient to CT scan without stabilizing. Then adjuncts, if patient has got some sort of brain skull injury, base, then please do not put nasogastric. Do the orogastric intubation. And before putting in a catheter, you should look for the injury to urethra, whether male or female. Now the fast has become the order of the day, so you can delay the catheterization because you will see better if the bladder is full. So therefore, you just do the fast and do the catheterization later on. And ECG and ABG, you all know and should do it. As I can see, even if you do cystoscope, the CT scan, sometimes the pancreatic injury or the colonic injury, they are missed. So you should have high suspicion in your mind and in the follow-up. Right? Now, what are the pitfalls with delay the management? Basically, masking of the abdominal signs. Suppose there is a spine injury or patient is intoxicated, patient has taken alcohol or illicit drug, patient has got cervical spine injury or thoracic spine injury, patient is not having sensation in the abdomen, and you have palpated, you found that there is nothing, and then you miss and the patient is being delayed, the treatment is being delayed. So that is all pitfalls you have to see, or the patient is taking beta blocker. You have not asked for the history and the pulse rate is not going up. You say, okay, pulse so is only 80, but you do not know patient is on the beta blocker. So all these pitfalls are there, you should be taking care of. Indication of laparotomy, you all are surgeons, you know that whenever the patient is a transient responder, a non-responder, patient is a case of blunt abdominal trauma, you should go for laparotomy. In all the penetrating trauma where it is obvious evisceration or you can see the pass-through, then there should be laparotomy. Now, something about pelvic fracture. There are 3 pictures. The 3 pictures, as you see, normally when there is an anterior-posterior compression, like somebody is hitting, like in our case, head-on collision, then these pubic symphysis, they will gape away. and some part will go up because of the uncontrolled tension, and then this is going to bleed more. This is what is known as anterior-posterior compression. Then the lateral compression, somebody is hitting from this side. Then what is happening? The pubic rami, they are happening, but the limb is getting internally rotated. So it is reducing the pelvic cavity. It is not that detrimental. While this one is rotating the limb externally. So whenever the limb is rotated externally, you have to rotate internally, apply pelvic binder, and then do whatever you feel like. And the vertical shear, when patient is falling from the above, he has got vertical shear, the iliosacral spines, and again this is a very detrimental condition, bleeds more. This is a short algorithm. As soon as you get the fracture pelvis in the X-ray, surgical consult, you all are surgeons, otherwise not. If you suppose, and do a pelvic wrap. You do the fast if there is a blood. Answer is yes, go for laparotomy straight away. If you do fast and fast is negative, then go for the pre-peritoneal packing, operative. If facility of angioembolization is not there. But since you are working here you have got the facility of the angioembolization, you can involve your interventional radiologist and they can do that. And then of course later on definitive treatment has to be done. Right. Follow up. अगर नॉन ऑपरेटिव मैनेजमेंट कर रहे हैं तो हम नॉर्मली 2 से 4 हफ्ते के बाद बुलाते हैं, पेशेंट से बोलते हैं अकेला मत रहो, और उसको वार्निंग साइन डिस्चार्ज टिकट पे बोल देते हैं कि जब हमारे को आपको इंटेंस पेन हो या देयर इज ए शॉक हो, सिर हल्का लगे तब आ जाइए. और नॉर्मली डॉक्टर साहब कितने दिनों बाद जाएं हम, तो 3 से 4 महीने बाद, या अगर सीटी स्कैन पे हीलिंग अच्छी हो गई है तो जल्दी भेज सकते हैं. ये सब कॉमन क्वेश्चंस हैं, आपको धीमे धीमे आ जाएंगे. कोई और सवाल बचा हो तो बताइए. इतने शॉर्ट पीरियड में इससे ज़्यादा मैं आपको नहीं बोल सकता. एनी क्वेश्चन? If not, then take home message is identify mechanism of injury and shock and restore vital function first. That is very important. Giving oxygen. Then prompt hemorrhage control and give IV fluid crystalloid to start with and blood as soon as available. Plasma versus RBC versus platelet 1:1:1. Then don't be afraid of using tranexamic acid if you are getting patient within 3 hours of injury. Please give it. It is going to save your patient. It is absolutely a standard protocol followed all over the world. You have to prevent and take care that hypothermia should not be there. Please, please, please do not shift any of your trauma patient to CT or MRI before stabilizing. Thank you very much.
Thank you, Vinod Jain sir, for giving such a detailed dissection of this topic in a short span of time. Now I would request Professor Shaleen Yadav sir for felicitating Professor Vinod Jain sir.
Next, I would request Professor Anit Parihar sir to please come upon the stage. Sir is head of the Department of Radio Diagnosis, and he will give a talk on how to read CT scan of the abdomen. Welcome, sir.
Dr. Geetika and Dr. Abdi Sonkar sir for giving me the opportunity to talk about CT abdomen, the normal anatomy of the normal anatomy of So will the slides come up? Okay, thank you. So in the next 15 minutes, I will talk about and discuss the anatomy, the CT anatomy of abdomen. So as Professor Vinojan sir outlined the anatomy by surface markings, I will be talking about the CT anatomy. So first of all, again you should know some few terms which we often use. So when we do CT scan, we use a plain CT scan, which is also called non-contrast CT scan or non-enhanced CT scans, NCCT or NECT. In that, basically we have not given the IV contrast. And then we talk about CECT. In CVCT we have given IV contrast. Now here we are silent on whether we have given oral and parectal contrast. So usually the two meanings. Now with the advancement of very MDCT, that is multi-detect CT, our acquisition has become fast and we can actually capture the bolus at different phases. So what are the phases? So when we inject in the antecubital vein or in the arm vein, it goes to the heart, then comes into the systemic circulation. Initially it will be in the main arteries. So this usually just for a rough purpose, usually in the arteries till first 20-25 seconds of the time it is in the arteries. When we are talking about organ anatomy and the phases, then basically it comes around 35 seconds in the liver. So what we are talking about liver is basically late arterial phase. In arterial phase, it will be actually in the arteries but not in any organ, and so it is not of much use. The phase which becomes important is late arterial phase, that is 35 seconds. And then we also note that liver has got a dual supply, it has got a portal venous supply also. In that it comes around 60 to 80 seconds of time, the blood comes through the portal venous, and this we call portal venous phase. So what is the importance? There are tumors, of most of them malignant, which take the supply from the arterial side, and they will be enhancing in the late arterial phase. So if you are going to look for a mass lesion and you are worried whether it is a primary liver tumor, then we have to get a scan of late arterial phase. But for most of the purposes, we need a portal venous phase. And then we can also, for some purposes, like we want to see the in hemangioma delayed image or in adrenals, or when we want to see the kidney KUB function, excretory function, then we also take a late phase. So that is called delayed phase. So these are the phases, and just to see your appearance, so you can recognize this is non-contrast CT scan because there is no, the aorta is not showing any hyperdensity or enhancement. This is the arterial phase. So in this hepatic artery there is some flow, and also in the splenic artery there is flow, in the aorta it is flow. Portal venous has just begun to enhance, but liver is not so much enhancing. Then you see the portal phase. Now the portal, because it is a normal liver, normal anatomy, so now the liver is being supplied by the portal blood supply, and it has enhanced more, and you can of course see blood in the portal venous branches. Then coming to delayed phase or some venous phase, then the washout has happened and enhancement of most of these structures have gone down. So coming to whether we have to give oral contrast or not. So now the newer trend is not to give oral contrast, but for many of the cases we are following still giving contrast, but slowly I wish as our machines are improving, for most purposes we will be able to either remove positive oral contrast or we will be using negative oral contrast. So let us talk about that. So we give positive oral contrast and it is still useful when we are looking for leaks. So we give positive contrast in the bowel, and if it moves out of that system, we know it is leaking. Then second, there is already an interloop, there is some expecting we have some collection. Now we want to differentiate. If we are giving water contrast or negative contrast, then we will not be able to differentiate whether the fluid we are seeing is within the lumen or it is out of the lumen. To differentiate that, we will be needing positive oral contrast. And then of course, when we are looking for communication between two bowel lumens, GI fistula, and in CT coronography we are giving most of that purpose is done by the air, but we want to, if there is some feces, then we want to tag prior tagging. For that we may need positive contrast. But what are the disadvantages of for giving oral contrast? What is happening? The oral contrast is not evenly distributed, so you are not sure whether there is some obstruction, that is why contrast has not gone distally, or it has not been allowed to go by that time, the time has not been given. that it is going to that time. And also moreover, with time, passes of time and passes of contrast through the lumen, it gets diluted. The second thing is, when we are giving one of our concerns is when we are giving positive contrast, then the CT machine is now equipped with AEC, automatic exposure control, and it reads that the number of photons reaching the detector are less, and what it tries, it increases the radiation. So the patient has to is given more radiation. And the third, if we are looking for bowel wall enhancement, then it is obscured by a positive contrast. Rectal contrast again is given when we are trying to look for perirectal abscesses, fistulas and leakage. So what are the, and so after knowing the indications, we have to also know when we have not to give the positive contrast. We don't need contrast when we are looking for vessels or arteries, because what will happen, positive contrast is also white and your IV contrast is also white, and when we have to, both are white, when we want to reconstruct the arteries and MPR images, you will not be able to trace out because the bowel lumen and when the vessels are running close together, it will be different to make out. And when they are leaking or bleeding, then also it has become difficult. For mesenteric ischemia, again we have to do MPR images where the contrast is going and where is thrombus, again we find it difficult, and in CT angiography we are give negative contrast. The same thing, it lies in acute blunt trauma because it is again related to blood. Blood is hyperdense and contrast, your positive contrast is hyperdense, and again it is difficult to differentiate between the two. Stone, they are also usually hyperdense, and there is also some risk of aspiration, then also we tend to avoid the positive contrast. So after that comes to, again now we have got one mechanism, we have got a negative contrast. What is negative contrast? Their density is even less than the soft tissue there or the water there. So one of the things we have is mannitol and PEG, and most of this we are using in CT angiography. Now there again we have to modify protocols, so that's why we want that you should write what you want to see. So if you are looking for something in the pancreas, or if you are looking for necrosis in pancreas, then we have to image. Pancreas is a very richly vascular structure, it enhances early, 35 seconds. So if you want to look for necrosis, this is the ideal phase when we should image. If you have not asked for this pancreatic phase, we will taking in the portal venous phase, which is at 60 seconds, and we will missing many of the pathologies of the pancreas. In ileus, one of your important question is whether there is strangulation or not. Strangulation means enhancement, and enhancement in early enhancement. So again we want to take the 35-second scan. Coming to the anatomy itself, for which is the class. So we can start. So what we take is usually we take from above the level of diaphragm to the pubic symphysis, and you can get a lower part of the heart in your first section. So again you can see this is your heart, this rounded structure, this is your aorta, and these are the pulmonary arteries. And when you can change the window, you will be able to see the basal part of the lungs. And what we want to see? You want to see the atelectasis, infection, aspiration and nodules in this part. Then in the basal sections again you can see the pleura, the pleural cavity, and any effusion, or if in the malignant things, pleural nodules you can see there, thickening plaques can see. Then you will get the top of the liver, and what you can see here, you can see this central structure through the esophageal hiatus is the esophagus. You can see any thickening, mass, adenopathies, hiatal hernia or varicose veins around the esophagus. And again what we have highlighted in this color, this is the IVC, and in this their right hepatic vein and the middle hepatic vein are going into this. So this is your hepatic veins and IVC junction. And you can see this well, even the left hepatic vein is, you can see here. So all the hepatic veins. Coming some section below, you will be getting the G junction area. So I have highlighted this here as yellow, and you will see that the veins have become more distal, they are more distally. This structure which is bounding the liver is your diaphragm. Then your gastric fundus and body will come. Again, what you think in the hollow organs or the stomach, you want to see for any thickening, any mass, the enhancement or the position. There may be some gastric volvulus or there may be hernia, you may see there. And here what you see, between the stomach and the liver, you are seeing a fat density structure with some vessels coursing through. So this is your gastrohepatic ligament. And now what you are seeing? You are seeing, well, two organs, solid organs. You have already begun to see, but I will explain in this slide. So this is your liver and this is your spleen, and this big structure, this vascular structure is your portal vein, the left portal vein. And here you can also assess the morphology of the liver, enhancement, masses, and same thing in the spleen. Coming below, in the liver, what you will see, this is a structure which is either hypodense or fat filled, and this is your basically a structure of ligament teres, and this is ligamentum virosum, and this will be your caudate lobe. And you can see the structures running towards the lesser curvature. These are your left gastric artery and vein. These are direct branches of the celiac artery. Coming below, this you can see a Y-shaped structure. So this is the body of the adrenal and the limbs of the adrenal. Same thing here on the left side. If you see the portal vein, this marked in lavender or pink color, anterior to that you can see your bile ducts. So normally it will be difficult to see them, or if you are trying to see closely, you will able to find them. But it is important in those things where there is CBD obstruction and intrahepatic biliary radical alteration. So here anterior to the portal vein, here you can see your CBD. And here just, so you have got the three structures. This is the portal vein, this is part of CBD, and your part of the hepatic artery, which is divided right here at right hepatic artery and the left hepatic artery. And this is your part of the celiac trunk, the common hepatic artery and the splenic artery. And this is the splenic vein, and this is the portal vein. So now I already talked about this. So you are seeing the celiac trunk, which is dividing into your common hepatic artery and the splenic artery, and along with that is the splenic vein. And what structure you are seeing here is the crura of the diaphragm enclosing the aorta. And so what structure you have identified here is coursing into the liver is portal vein. Here you have your aorta. Lying beside the aorta, this enhancing structure is IVC. And there is another additional structure in this case between the portal vein and an IVC, which is called the portocaval lymph node. And here you can see the pancreatic body and tail, this shaded structure pancreatic vein, and it lies anterior to the splenic vein and the confluence of the splenic and the portal vein. So this structure will be your pancreatic body and tail. And along along the aorta and the celiac artery, these are your celiac ganglion. Now we have come to the part where we can see the gastric antrum, and then it will be giving way to the duodenum. And now here you can see the cystic duct here, and this is the gastroduodenal artery. And the thing I was talking about, this is the portosplenic confluence of the veins. And so now one of the anterior visceral artery, celiac artery is gone. We are at the level here of the kidney, and what we can see here is superior mesenteric artery. And here what we can see is this is your IVC, and into it this the blue from transverse structure is the left renal vein, and from the aorta you can see the renal artery, right and left renal artery. And from the stomach, what is happening is this triangular structure is the duodenal bulb, and we can also see the gallbladder. Again we have to look for gallbladder size, wall thickness, stones, inflammation. So this is again anterior to that, this is the SMA. Besides that is the SMV to the left of the SMA, and in this section you can also identify the inferior mesenteric vein. And we are seeing now the pancreatic head here. This is the pancreatic head and the SMV. of course you can see the kidneys with their hyla anteromedially rotated, and this is our aorta, this is our IVC, this is the renal veins. Besides the aorta, we were able to see some aortocaval lymph nodes in this case. This is a bunch of bowels, small bowels with lot of feathery appearance. This was our proximal jejunum. This structure is basically the splenic section of the descending colon. And what we are seeing here is the second part of the duodenum, and this is the aorta IVC with some lymph nodes around that. This hook shaped process is the uncinate process of the pancreas, and this is the ampulla. This is the ampulla which is opening in right into the duodenum, second part of duodenum, and these are structures are basically which run near the kidneys are the ureters. Now coming to this, so this is your peritoneal cavity, and we have discussed many of the structures. So we like to see the free fluid, air, collection, implants, thickening and enhancement, and here bounded is the retroperitoneum, and we are of course the kidneys, ureters, adrenals, and other than that is we are want to do aorta, IVC, adenopathy, masses and fluids. So just I will rush through, I have already exceeded the time, and again ascending colon and descending colon here. And here is the subcutaneous tissue musculature, muscles. And one thing I would like to show the appendix. So after identifying the cecum, we can see this tubular structure. This is your appendix. This is your appendix. So with this, I would like to close my talk. If there is any question, then I will be answer, because few liver anatomy is left. I wanted liver anatomy and peritoneal spaces, but there is no time for that. So I will end my talk here.
You can continue.
Thank you. Any questions?
So you can continue.
I can continue. Okay. So one important things I can maybe continue is, this is your peritoneal spaces, folds and ligaments. So this is one of the coronal sections through which I would like to explain this is the stomach, this is the liver, there is a ligament, because this patient had a lot of fluid collection. So many of the ligaments we were able to identify. So this is here the gastrohepatic ligament, and from the duodenum to the liver we can see the hepatoduodenal ligament. This is a plain fat-filled plain. This is basically due to the transverse mesocolum. So now the transverse mesocolum has divided the intra-abdominal peritoneal cavity into two spaces, the supramesocholic space and the inframesocholic space. In the inframesocholic space, there is a small bowel mesentery, and there is the sigmoid mesocolon. Now coming to the spaces, so this is section somewhere posteriorly. This fluid is basically into the right subphrenic or right subdiaphragmatic space, and below this is the Morson's bond between kidney and the liver is your right posterior subhepatic space, also called the Morson's pouch. Posteriorly we can also see around the spleen, this is the perisplenic space or the left posterior subphrenic space, and here you see can imagine that there would be some part of the left lobe of liver. So this space is called left posterior subhepatic space. Coming anteriorly, so again below the diaphragm is the subphrenic space, which can continue here, and all the left segments will be here. Now after identifying your middle hepatic vein and where it is joining the IVC, you can also try to identify the right hepatic vein. So when if you identify the right hepatic vein, what it does, it divides the anteriorly, there is the segment 8, and posteriorly that is the segment 7. So your 7 and 8 are clear. Now left of that the middle hepatic vein is yours, and touching that is the segment 4. And in subsection you will be able to identify your falciform ligament or umbilical fissure. You try to trace it upwards, and somewhere, if you trace it up, you can draw this blue line. So middle to that or towards the left side will be your segment 2, and of course I told you touching that is segment 4A. So that same thing we have continued here. coming to somewhere below where you can see the left portal vein. So, usually this left portal vein and the umbilical fissure correspond, and to the middle side is the your segment 2/3 and to the lateral segment 4A 4B, and here you can see 8 and 7. Coming below here it is the same thing, but by this time what will happen is your segment 3 will start coming, segment 3 will start coming, segment 3 will start, because here left portal vein is there and then there will be right portal. They are not in the same level on CT scan. So, you most of the time you are not able to see in the left portal vein here, and here there is the right portal vein. This is section somewhere in between. So, I would like to explain the right portal vein. Again, follow the right hepatic vein which will give your boundary between posterior segment 6 and anterior segment 5, and touching that will be segment 4B, and if you identify the falciform ligament, this will be your falciform ligament. This is your segment 3 to the middle side of falciform ligament. So, this way we can divide our liver into 8 segments. Okay, thank you.
Thank you, sir, for your detailed explanation of the CT of abdomen. So, I would request Professor Surel Kumar sir to amend citate Professor Parihar sir. So I would request Professor Shane Yadav sir. He is professor and head of department thoracic surgery, and he will be delivering his talk on the topic of tracheostomy and its complications.
दिखाओ यहाँ से लो, ये तो जेब में रख ले, ठीक। So good afternoon, the organizers and especially Geetika and the whole of the department. I am also the part of the department, but recently moved to the thoracic surgery. So my topic is the tracheostomy and intubation, means airway. So airway management is important, you can say very important, because we are dealing with the day-to-day, I think in surgical field, in the department of surgery, we are seeing the complications of tracheostomy and the endotracheal intubation. So you see that the complications are very troublesome sometimes, and even up to the death in, I think if there is, the saying is that no symbols like airway symbols. So in many cases, if you have the complications, so if there is some, I think more complicated scenario, the death up to the 50% of the patient. So you should be careful. So planned tracheostomy and endotracheal intubation, it is very straightforward, definitely, but you must be cautious about the complications and how to, the process, how to do it. So I think immediately like airway fire, especially when under, I think under anesthesia. So sometimes it happens, I have not seen, but that is described in the literature. So bleeding sometimes troublesome, especially the anterior jugular vein, and sometimes the from the thyroid. So that may be troublesome, and if you see the huge bleeding, it even choke the whole of the tract, and patient dies. So there are long-term complications also, so that we are dealing day to day. You see the anatomy, the structure, that so many important structure starting from the thyroid, I think isthmus, it comes anteriorly to the other major vessels. You see the arch of the aorta, the innominate vessels, both arteries, even all are related. And posteriorly you see that there is esophagus also. This, you see the tract, the airway tract. Here you are seeing this thyroid membrane and this cricothyroid space, I think ligament and all the structures. So in this slide you see the supply of the trachea is the thoracic, trachea has the thoracic and as well as the neck part. So cervical and thoracic. So it is mainly supplied by the inferior thyroid vessels and the bronchial arteries in the thoracic part. They all make the communication. You see, the communication arch is there. So both the I think the regions are supplied by one another. See, the indications are definitely, you must be knowing that secure the airway to bypass the obstruction, especially in the trauma cases, elective ventilation in surgical setup, and positive pressure ventilation in the ICUs when there is respiratory failure. So assess airway for the control of secretions, especially in the for the tracheostomy. This is for the tracheostomy in the long-term endotracheal intubated patient, and protect airway in neurological compromise in the medical as well as I think surgical cases or the trauma cases. So one question arises, why tracheostomy? You must have seen the tracheostomy in the post-op, I think post-intubation period. Why this? Because of it is the safe and long-term ventilatory access. So pulmonary toileting is important. So long-term intubation becomes difficult to manage also. So toileting is needed for the suction purposes, improved oral hygiene and decreased ventilator-associated pneumonia, elimination of 25 centimeter square of the dead space. So this decreases the dead space also, that is very beneficial, and increase verbal communication and options of the weaning. It's definitely very important things which has to be taken up. You see now the tracheostomy, this is the open method, mostly practiced. So like you see the incision, depending upon the, I think most of the emergency cases, the longitudinal incision is given, but definitely the more cosmetic will be if you give the transverse incision. So it depend upon the expertise as well as the scenario which we can do. So anesthesia limit up to the less than 30% should be the concentration, because of the sometimes the fire happens. So strap muscles are retracted, and the thyroid isthmus is divided or retracted. So second and third cartilage with the vertical incision, this author has practiced the vertical incision. There is always controversy whether the vertical or the transverse, but usually as I see, the transverse will always be better incision. So if you think of the I think the later on the complications of the stenosis, so that is debatable, but in emergency situations mostly people give the vertical incision. So into tube you have to adequate tube, and you have to flanks to be fixed. So now the another is the cricothyroidotomy, so or the mini tracheostomy. This is the kit which is used as a percutaneous method. You see, so you can palpate the cricothyroid membrane and you can put the needle. So in emergency situations we need sometimes. And there is another method is percutaneous tracheostomy. I think very less commonly practiced, but maybe sometimes if patient is intubated and you already have all the bronchoscope, and if there is chances of injury to the esophagus posteriorly, in those cases you can practice that, but very less commonly practiced. So the controversies in the ICU, the early or the late tracheostomy, I already told you that it should be done depending upon the scenario, especially the head injury patients. There should not be early, delayed. There have been certain studies where delayed tracheostomy is needed in the head injury patients. Otherwise, most of the cases should have the early this tracheostomy should be done. Now the transverse or horizontal incision, it's both for the skin as well as for the trachea. I already told you that there is some people are telling that should be vertical incision, and some are. I am practicing the I think the transverse incision. I think it is more advantage in terms of the development of the stenosis later on. So the complications are, you see, very important are the venous bleeding up to 1 to 2% in open and up to 5% in percutaneous procedures. So you have to take care of that. Arterial bleeding is less, mainly it is venous bleeding, especially the anterior jugular vein, and the injury to the great vessels, like great vessels, very uncommon, because it is quite I think in the thoracic part, or you can say the thoracic outlet. So injury to the great vessels very uncommon. Esophagus sometimes it happens. We have seen that. Recurrent laryngeal nerve injury, and mediastinal intubation and pneumomediastinum sometimes happens, and pneumothorax, aspiration. These are the uncommon complications of tracheostomy. Early complications are like bleeding from the surgical field, and if the patient has already have the coagulopathy in the head injury patients, or sometimes long-term intubation. In those patients also, the chances of bleeding is there. So, dislodgement can be very fatal, means if the tube is dislodged, sometimes in the hurry you can even put in the mediastinum and there is no, I think it is not in the good, I think appropriate place. So, in those cases it is very troublesome. So, mucus impaction may happen very, I think it happens commonly. Subcutaneous crepitus, air leak is due to the tube is not in the proper space, or even in the tube in the space, then sometimes if there is air leak, this this crepitus can be there, and infection leading to the cellulitis. And sometimes if there is sternotomy has been done, suppose in those cases where the thoracic surgery or some maybe some indication due to trauma. So, in those cases if sternotomy wound is infected, that is very troublesome to manage. So, late complications. So, basically I see most of the late complications in terms of the stenosis mostly. So, they are very challenging and has much mortality and mortality, as I told you in the beginning. So, bleeding from the granuloma or TIF means the tracheoinnominate fistula. I have not seen, but it is described. So, if there is innominate vessels or there is fistula, then it will be troublesome. So, very troublesome, can bleed a lot, and definitely the death is will be definitely in those cases. Tracheoesophageal fistula, I have seen many cases. So, persistent tracheostoma, if it is more than 6 months, it persists and you are not able to anastomose or not able to manage, then it becomes persistent and definitely have to for the lifelong. There is no option there. And tracheal stenosis or Malaysia, which is very commonly practiced. So, the important is the tracheostomy care. It is very important, we have to take care of that. So, we have to prepare properly, proper washing, proper antiseptic precautions should be there. Inner cannula care, if already have done, we have to care, we take out the cannula, I think inner cannula and clean it. Then the stoma cleansing is very important, sometimes the infection is very troublesome, already told you. Dressing change should be there, and tie change means all the, I think with the aseptic precautions we have to do that. So, now we have to, what should be the, I think emergency kit should be there always. So, always keep a spare clean tracheostomy tube when we are dealing with the cleaning and whatever the changing or the I think mucus plug removal, whatever you are doing, there should always be emergency kit available, should be humidified air. So, humidified air must have used, especially the mostly of the time you use the gauzes which should be soaked in the saline, and so that the moisturized humidifier should be done. So, monitoring, inspect the skin and the redness or the swelling if any spreading infection is there, and avoid water, powder or dust near the stoma. So, when to seek the immediate medical attention in cases where dealing with the tracheostomy. So, difficulty in breathing or the severe coughing. Mostly it happens when there is blockade, especially the mucus plug. So, if tracheostomy tube becomes dislodged, very emergency situation, you have to actively manage. Signs of infection, so definitely it can spread and cause lot of problems, and bright red blood or large amount of blood in the secretions. So, there is some chances of bleeding. You have to very cautious for that. Now, the management is depend upon the what is the scenario, like immediate if and early. So, like bleeding, dislodgement already have described, if that is there you have to manage accordingly. Late complications like the tracheoinnominate fistula, there are so many things, I think methods like described, that you have to put the bulb there depending upon where it is and what extent it has gone, and be prepared for immediate sternotomy and management. So, by the time you can give the pressure through the tube and then shift the patient in the theatre and do accordingly. So, late complications like all these infection all have to manage, and stenosis needs special attention because we are dealing with so many cases of stenosis. So, you see, so tracheal obstruction, when how it happens can be due to malignant, but mostly by the non-malignant scenarios as we are dealing with. So, this endotracheal intubation and tracheostomy is the most common cause. We are getting so many cases operating also. So, minor lesions can be managed endoscopically, like a small wave or like that. A small stenosis means not circumferential, but part of the circumference, that you can manage endoscopically. And surgical definite management is a surgery, surgical resection. So, half of the trachea can be resected comfortably, not comfortably, can be resected, but with effort, like the procedures are described, like you have to, in cases you have to release the trachea from the hyoid, you have to hilar mobilization, do the sternotomy, and whole of the hyla is elevated, with even sometimes needed the incision over the pericardium. So, you can put the layering, means the trachea below from the neck, and you can push the, I think, take the both the hilum of the trachea, lower part of the trachea above by all these procedures, and you can, half of the trachea can be resected. So, longer lesions in most of the cases into an anastomosis is possible, and that is the only definite treatment. So, longer lesions, suppose the more than half or sometimes not feasible, in those cases total palliation can be for the lifelong tracheostomy, or sometimes stenting, which is not very definite method for some time. You know, any foreign body is very difficult to tolerate in the trachea. Even single drop of cough, you see so many coughing is there if airway means any fluid or whatever goes, or the foreign body. So, that is only the palliative, I think, stent is the method, and tracheal transplantation and regeneration, I think regeneration is very, I think, not so much feasible in very small lesions can have regeneration if there is mucosal and only the epithelial damage, only very superficial for the short length in those cases. So, why this is surgical management difficult for the trachea? Why? Because it is unpaired and unique structural rigidity, short length and relative lack of elasticity, proximity to the major cardiovascular structures, and segmental blood supply. So, sometimes the conservative management like poor surgical patient, or you have the smaller lesions. So, endoscopic repair, I think the management sometimes very few scenarios you see thin band or a scar like that, or sometimes adjunct to the procedures we already do in the open method. So, in the definitive method, the long open is the open repair like resection and anastomosis. So, there are certain pictures of seeing the trachea. So, you see the long segment here. So, there are different pictures of this tracheal stenosis. These are some operative, I think, photographs. So, message is that tracheostomy is a simple procedure, but can be disastrous when performed by inexperienced hands or without precautions. Endotracheal intubation and tracheostomy in ICU needs a special care. Proper identification of complications can be managed accordingly, and stenosis can be managed surgically with excellent result. Thank you. टाइम से हमने कर दिया खत्म.
Thank you, sir, for your detailed presentation. And I would request Geetika ma'am to felicitate and Dr. Pankaj sir. He's from Integral Medical College, and he is head of professor and head in Department of General Surgery in Integral Medical College. Thank you, sir.
You can all stand and sit. Please stand. Because there's no coffee break. You can just straighten your legs till we move to the panel discussion. Sir, आप आ जाइए. There's no coffee break. Coffee will be served here only. Achika ma'am, please come. भेज दे सर. 5 मिनट से पहले आएंगे नहीं सर, फिर भेज दे. You can select 2 people as the panelists, ma'am.
any students want to volunteer to come to make a clinical diagnosis test? Otherwise, I will pick 2 or 3 students. सारे भाग लिए देखो वॉलंटियर कराने के नाम पे. देखो सारे भागे एक साथ. You are? They are? You are, sir. Post MS. Post MS. For what? Okay. दो और लगा दो. 2 और इसके बाद. नहीं और चाहिए होंगे. और चाहिए होंगे और. रेजिडेंट आएंगे ना थोड़ा सा उधर की तरफ रख देना.
We can even have a JR, SR as the panelist for you, ना?
वही है ना.
रजत, आजा.
हाँ तो बुलाओ किसी को भी 2 लोगों को. हाँ
मैं आया.
सर ने भेज दिया. सर ने कहा कि एक अमन है और दूसरा क्या है बाहर से कौन मैनेजर है. अच्छा
रजत. आजा आजा. There won't be many questions to you. Where are you from?
Not very question. Just what's name? Geetika Anand. From where? GSP Medical. Just I just
गीतिका
asked.
तुमने किसमें डाला था? थायराइड पैनल में भी डाला तुमने नाम. CFS से पहले तुम्हारे में कि somebody else had volunteered. तो हमने उसको दे दिया इसलिए we're putting it for thyroid panel. That is tomorrow. That's okay. अभी इसमें आ जाओ.
Just we ask for the diagnosis only. And no problem. ठीक है? No question, more question. Okay? हाँ वो तो अब इसके बाद इनको मिलना चाहिए. थोड़ा सा इंटरेस्ट आना चाहिए अब तो. हैं? तुम्हारी वो लड़की कहाँ है? स्वप्निल. अरे अच्छा क्या नाम है बेटा? प्रियांश. अच्छा चलो कुछ नहीं करना बैठो. केस जस्ट यू हैव टू मेक डायग्नोसिस स्पॉट. प्रियांश एंड गीतिका. हाँ तो तुम बना ही दोगे. हैं बस फिर क्या है. सर आगरा से किसी को भेज दीजिए डायग्नोसिस में डालेगा. राजेश सर अगर आप आगरा से आए वो आप पढ़ाते हैं भेजिए.
Please call the residents back. Aman, call everyone back.
सर ने भेज दिया. सर ने कहा जाओ जाओ तेरे आगे.
सबको वापस बुला लो बेटा. Go and call everyone.
ऐसे बाहर खड़े हो करके. एक बात सर आ जाए बच्चे. बच्चे आ जाए सर तो आपने भेज दिए सब कुछ. was JR3 and you are JR3. तुम्हारी तो पोस्टिंग हुई है ना हमारे यहाँ पीडियाट्रिक सर्जरी में. सो यू हैव सीन ऑल दी केसेस, मोस्टली केसेस. बस वही देखे तुमने, बाकी केस नहीं देखे तुमने. ऑपरेट नहीं कह रहे हैं वार्ड में, तो सारे केस एडमिट होते हैं. यू हैव टू सी. Good afternoon all, and at the outset I just like to thank Department of Surgery to invite me as a moderator in this panel discussion on the discussion of the pediatric surgical cases. So I would like to invite first our panelists. So first I would like to invite Dr. J.D. Rawat, Professor and Head, Department of Pediatric Surgery, King George Medical University, Lucknow. And Dr. Rajesh Gupta, sir is Professor and Head, Department of Surgery, SNMC Agra, and sir is also heading the unit of pediatric surgery in SNMC. Dr. Basant Kumar, he is Professor and Head, Department of Pediatric Surgery, SGPGI, Lucknow. Dr. Anand Pandey, he is Professor in Department of Pediatric Surgery, KGMU, Lucknow. And Dr. Sudhir Singh, he is Professor in Department of Pediatric Surgery, KGMU, Lucknow. So, I welcome you all, sir, and I hope this panel discussion will be helpful to these postgraduate students. So, first I will start with this case. So, if a 12 months male comes with a complaint of the asymmetry of scrotum along with the absence of the left testis in the scrotum since birth, and on the history the baby was full term normal with normal vaginal delivery, no perinatal complication, no family history of genitourinary anomalies, right testis on examination, right testis palpable in scrotum, left hemiscrotum hypoplastic with less rugosity, left testis not present in scrotum but palpable in mid-inguinal region, and no associated anomaly. So, Priyansh, can you tell me what can be diagnosis? Huh? Full diagnosis can you make? I just made an examination. Made it palpable or not palpable, okay? So, it is a left palpable undescended testis, okay, with no anomalies, okay? Yeah, sir. Yeah, residual, sir. So, Dr. Sudhir, what can be other differential diagnoses and how will you differentiate?
The other common differential diagnosis in such type of cases are, what most common is ectopic testis. Ectopic testis, in which testis is descended from abdomen, but after descent it deviated from its paths, and it may be at the superficial inguinal pouch or at the root of penis or at femoral location or perineal, or maybe sometime into deviated to contralateral opposite side scrotum. Another common differential is retractile testis. Testis is descended and it can be manipulated up to base of the scrotum, and after manipulation it stay there at base of scrotum. That differentiate from undescended testes. In undescended testes, after manipulation, testes again retracted back to inguinal area or higher position. Another differential is ascended testes. Previously, testes is in intrascrotum, that is noted by mother, or some diagnostic investigation recorded that testes is in scrotum, and in later time the testes is not in scrotum, that is ascended testes. So these are the common differential of this condition. During examination you should keep in mind.
So, Dr. Sudhi, you have rightly pointed out the differential diagnosis and all the points validly mentioned in the differentiation of these conditions. So, Dr. Basan, we routinely see in our OPD that patients usually refer from outside with the imaging such as ultrasound or sometimes even with the MRI. So, is there any role of imaging in this such kind of palpable or non-palpable undescended disease?
MRI or ultrasound usually pupils performed in private practice or somewhere, but yield is quite less. If you see, if you directly palpate, no investigation needed. If it is a intra-abdominal, and if you do MRI or ultrasound, ultrasound yield is quite less than 30%. And if you do MRI, it was reported in few articles, it is approaching 100% for diagnosis, but it's not true. And fear is that if MRI shows false positive, suppose that testicle is absent, and they are reporting there is testis is present, and you go for surgery, and you could not find the surgery, then that is very difficult situation to explain to parents, because he will say there was testis, but it was shown in MRI, so it should not be done. If testicle is palpable, go for surgery. If intra-abdominal, laparoscopy is gold standard. One point I would like to add.
Yes, sir, definitely.
That if the testis is palpable, go ahead for surgery. But for medico-legal point of view, you must go for the scanning, because sometimes there is a legal issues occur, and then you have to go for to document that this was the testis. If it is palpable, even though, because sometimes there may be associated with intra-abdominal associated anomalies, maybe renal anomalies or ureteric anomalies, something like that. You can detect, right, without any symptom to the patient.
Sir, you are right. You are right, but
Ultrasound can also give you an objective assessment of the size and the volume of the testes, which can be used as a prognostic marker for the subsequent for the time after you do orchiopexy. So ये बताना जरूरी होता है parents को कि कई बार क्या होता है, many times the size of the testes is little bit smaller, or sometimes it is significantly smaller.
so
So
better
that's why
है
we
कि
need to document
better
it.
if we mention in the operative notes it is the size of the testes, then we can also because ultrasound is operator dependent. So for I think for students it is better to mention that imaging is a least role if testis is palpable, and non-palpable diagnostic laparoscopy is the gold
Laparoscopy
standard.
is best, because ultrasound or MRI give false report of larger size of testis. That is always very difficult to explain parent. Actually, testicle is very small when you operate, but ultrasound give.
So, Dr. Anand, can you just classify how it is classified and why it is important to classify the undescended testes?
Undescended testis broadly can be classified as either palpable or non-palpable testis. This is the basic one, and its differentiation is important because an palpable testis, you can after verification, your clinical examination, and as suggested by the panelist, an ultrasound abdomen. If such is the case that the test is present in the inguinal canal, you can straight away go for the definitive surgery, that is standard inguinal orchiopexy. In case of non-palpable testis, you need to go ahead. I think the discussion has already been made about the modalities to be used. Apart from non-palpable testis which can be found, there may be a possibility of a vanishing testis or absent testis, or in vanishing testis, testis was formed but that vanishes during the fetal life, or testis was not formed at all. Otherwise, beside these, one condition was mentioned by Dr. Sudhir, ascended testis. That was initially something was present in the scrotum, but when the child grows, testis may ascend up. Third thing is a trapped testis. Sometimes after surgery for inguinal hernia, etc., if testis is not pulled back into the scrotum, testis may get trapped. In these patients also, as a complication of inguinal hernia surgery, herniotomy, ascended testis or trapped testis may happen.
Rightly said, Dr. Anand. But before labeling any as undescended testis, this is I just want to emphasize that before labeling any testis, undescended testis as a non-palpable, we must have to examine at the ectopic sites, and also we must have to examine just after induction of the anesthesia. Because in obese patient and sometimes the incooperative child, sometimes it is not possible to palpate the testes. So, Dr. Rajesh Gupta, is there any role of hormonal therapy in palpable or non-palpable, or if hormonal therapy has to be used, so what hormonal therapy can be used?
Personally, I believe there is absolutely no role of hormonal therapy, especially after infancy. In the initial few months, maybe up to 6 months, 5 or 6 months, in cases of bilateral undescended testes, we can try hormones like SCG or buserelin or gonadorelin, intranasal sprays. Personally, I have used it and I have not found it to be very useful. Success rate is very low, less than 5% or sometimes around 10%. And most of the cases in which we believe that hormone has worked, probably those are retractile testes only. So, in palpable testes, absolutely no role. In impalpable testes, absolutely no role. There might be some role in bilateral undescended testes, which are located near the neck of the scrotum. And in most cases, the testes which respond, they mostly turn out to be retractile testes only. So I don't believe there is any significant role of hormonal therapy in undescended testes.
Yeah, you rightly mentioned there is no role.
I would like to add only a point about it. There is a lot of controversy about hormonal uses. In America, they do not prefer hormone therapy, while in Europe, hormone therapy they give preferably many a times. And the claim they make is, as one said by the Dr. Rajesh, that it is can differentiate between retractile testis and undescended testis. Second, they say the semen content increases and is better when hormonal therapy is used. And third, occasionally it has been seen that the testis which are present at the deep ring may somehow come beyond that. But these are only studies. But if you want to tell about in your theoretical examination, these points you can add about the benefits of hormonal therapy if ever used.
So, rightly point out that hormonal therapy currently has no role, and if it has to be used, it's used in the early infancy and should not be delayed beyond 18 months. Okay.
In fact, it is dangerous. The vital time is lost while waiting for the testes to descend after hormonal therapy, and it may subsequently damage the testes also.
I used to prefer, if I just want to give hormonal therapy, I just want to give till the 9 months of age, not beyond that. 9 to 10 months of age, not beyond that.
Yeah, Archika, actually, what Anand was saying, European prefer, but American urological societies, they never advise it. If you just have to wait for 6 months, after 6 months, refer for surgery. And before 9 months, it must be operated. Hormonal therapy usually delays the time, a crucial time for surgery.
So now, Dr. Basant, what is the management for undescended testes and why it is needed?
Management is simple archaeopexy. If it is palpable, like this case, you go for inguinal exploration and making brought down the testis in the scrotum, make a subdaughter space and fix it there. And other question is
why this surgical treatment is
treatment
needed?
is required, because If it is in inguinal region, it is just over the pubic bone. It is more prone to trauma, especially in kids who is playing and falling by their chest and abdomen. So there is a problem of trauma or torsion also. And if staged long duration, there is chances of infertility because of morphological changes of morphological histological change of testicles and
So this is next
chances of
question to.
malignancy
So
at
that
last.
too I've already made it. I just want to ask Dr. Didi Rawat sir, ki what are the complications? So though mostly you have mentioned already. So
I think Dr. Basant have mentioned so many things, and I just make you their points. You just remember it. HI double T, hits. Hits means almost all undescended testes, they are associated with patent process vaginalis, right? And more than 90% they have chances of inguinal hernia. So H stand for the hernia. So you have to take care of hernia. This is one reason. I means infertility. It has been seen that the patient who have operated after 1 year, number of spermatogonia and spermatocytes become reduced because of the testis which is higher into the scrotum. They have a temperature difference of, body temperature 37 degree and scrotal temperature 33, and in between there is 34 35 something is the inguinal area. So testis which is present higher than the scrotal area, there are more chances for infertility, right? So the I stand for infertility. Then trauma, he has already told you. Torsion because of the testis which is hanging in the inguinal canal or somewhere in the abdominal cavity, they are not adhere at all. So they are hanging like a grapes. So anytime they can go under the testicular rotation and patient may develop the testicular torsion. Trauma, torsion and tumor. The incidence of tumor in undescended testis in general population is more than 8 to 10 times, right? So the testis which is intra-abdominal, they have 4 times higher incidence compared to the testis which is present in the inguinal area or into the suprascrotal area. So because of the tumor, there is a high incidence of these things. So you have to think for surgical intervention, and most common tumor is the seminomas followed by other tumors, right? And uh, uh, last one is that psychological trauma. You can add one trauma here, and that trauma for the psychological trauma to the initially for the parents that my son have no testis, number one. Number two, later on its trauma goes to parents as well as patient both, so you have to operate them. And last is that sometimes there is associated uh, separation of epididymis from the testis, which is again contribute to infertility. So these are the issue where you have to think for surgical intervention. Over to Dr. Raichu.
So thank you, sir. You have rightly mentioned all the complications. So, Dr. Sudhir, what is the optimum age for surgery and why?
In newborn, there is a chances of descent of testes up to 6 months. So after 6 months, surgery can be done between 6 months to 1 year. After 1 year, there is chances of testicular degeneration started. So ideal age is 6 months to 1 year. Surgery should be done.
So rightly mentioned, it is basically ideal age is 6 to 9 months, and but has to be operated by the 18 months of the age. So, Dr. Anand, if this boy would have come to you in the neonatal period, what would you advise the parents of this boy?
Like the last answer by Dr. Sudhir, if any patient comes to you in the neonatal period, डॉक्टर साहब बच्चे की गोली नहीं है एक तरफ की या दोनों तरफ की, what you need to advise is reassurance or things like you need not to worry as of now, be in follow up, wait for 6 months and come again. And if you are a pediatric surgeon who can manage the entity, treat it at the age between 9 to 12 months. It can be delayed up to 18 months if needed, but as per literature it is 9 to 12 months.
So rightly mentioned, Dr. Anand, wait and watch and regular follow-up till the age of 6 months. As majority 70 to 80% of testes descended by the 3 months of age and rarely beyond 6 months.
One comment I would like to say,
Yes, sir.
that why we are waiting for 6 months, after that we are operating. Any idea? It is expected that the testis up to 6 months will descend, and the reason is that testis have a control of testosterone, because the testosterone surge occur in the neonatal period and then another surge occur in the pubertal stage, right? So because of the maternal testosterone and this is secreting testosterone, there is a very high incidence that initial 6 months the testis will descend. That's why we are not touching the testis up to 6 months, and after that we are operating.
Rightly mentioned, Ravas. It's basically this testosterone surge in initial 6 months is called the mini puberty.
Is there one condition where we can do a, we have to do, or rather we are forced to do a neonatal orthopexy
So
if
torsion.
there is a hernia or a torsion?
If there is hernia and torsion, then you have to do in that period. So, Dr. Zedi Ravas, how, if this index case presented to you or presented to us, then how will you manage this case, and what are the principles of this surgery?
See, the basic principle is, standard is inguinal exploration and archodopexy, right? And the classical incision which is given as for the hernia, you all know, inguinal crease incision, open the canal, inguinal canal, right? And then identify the testis, divide the gubernaculum. But division of the gubernaculum is the most important, because sometimes the vas is looping through the gubernaculum and come back to the testis, right? So there is a more chances of injury of the vas. So during division of the gubernaculum, you must take care, right? And then after division of gubernaculum, you lift the testis up and separate the patent process vaginalis, which is present more than 90% of the cases, right? And you divide just close to the deep ring as you are doing in the hernia repair, right? And then you mobilize the testicular vessel in the retroperitoneal area. There is a lateral spermatic fascia which is called, or is known as Dennis Brown band. You divide that and you mobilize the testis till the lower pole of the kidney. You can nicely go by little retraction to the retroperitoneum, and then most of the time you can able to bring the testis down into the scrotum. So there is no issue of that. But testis sometimes is happen that even after mobilization you are not able to
Sir,
bring the
can we make fast, sir, because we have to.
Okay, thank you.
So if test. Yeah. Vas and vessel both. So, Dr. Rajesh Gupta, if this testis would have been non-palpable, then how will you approach it?
If the testis is not palpable, there are two possibilities. Either I am not able to palpate it when the child is not quiet, or child is not cooperative, or it is intra-abdominal. Or, so my approach is obviously to post the case for a diagnostic laparoscopy. That is the best method to look for any non-palpable testes, which are mostly intra-abdominal. But before putting in a laparoscope, after the child is anesthetized, I would like to carefully palpate the inguinal area and the ectopic sites for any evidence of testes. If I am unable to palpate it in a quiet anesthetized child, then I must proceed with my diagnostic laparoscopy, and I will put my scope through the supraumbilical or infraumbilical region, depending upon the choice of surgeon, and then I will look at the inguinal or internal ring, and where I need to see if I can see the testes hanging below or at around the inguinal ring or internal ring, or do I see no testes but the vas and vessel entering the ring, or I see atrophic vas or vessels just ending blindly at the or just before the ring. So these are three possibilities which I need to see. If I am able to see the testes, then I will proceed with my orthopexy. Okay. But if I am able to see vas and vessel entering the inguinal canal, then I must assume that the testes has descended into the inguinal canal, and I must go and explore the inguinal canal to find any atrophic or numen of a testes which might turn malignant later on, and I need to remove it. So this is a second possibility. But if I see blind ending vas or atrophic vas and vessel ending just before the deep ring, then I must presume that it is a vanishing testes, which is usually the result of a intrauterine torsion, which has happened and which has led to the loss of testes. Only vas and atrophic leash of the vessel is remaining.
So rightly mentioned, thus you, if this test is present in the, if it is more than 2 centimeter from the ring, so then it has to be done by the Fowler Stephen,
Yeah.
either in a single stage
Those
or
are
two
more
stage.
technical things, which is
So-
probably not for MS students.
So this has been already, if this undesirable test is present in the case of premature infants, so how do you manage this case?
I think the management of undescended testis in premature baby is almost similar like a full-term baby. So it's not a much difference. You have to again wait for 6 months and
But
then you think
this 6 months should be corrected age, sir.
Yeah.
This should 6 months should be corrected age. Corrected age means that if a baby is delivered at the 8th week, then 1 week that and 6 months that would have been normal age for the term. So further, if this child has presented the age of adolescent age, then how will you manage this undescended testis in
Even
adolescent?
for palpable undescended testis, the management is remains same like a fully descended testis, full term baby. So if whenever patient comes to you, if testis is palpable, you have to bring testis down into the scrotum, and the reason I have told you because of the complications. So whether it is coming in the pubertal age, pre-pubertal age, or any age, you have, if possible, palpable, then you bring into the scrotum, and then
So it has been recommended in literature that if it is small in size and atrophic less than 50% of the contralateral, then and it comes in the adolescent age, then we can do orchidectomy also.
yeah, that is definitely the small testis, newborn testis, just palpable small, then you can take out, or any doubt of malignancy because of the consistency or by previous ultrasound comparing right and left, then naturally you can go far and take out that.
So Dr. Rajesh Gupta, what is the fertility outcomes after orchiopexy, both in unilateral bilateral, whether orchiopexy will help in the regaining of the fertility potential in these boys or not?
See, fertility potentials depends upon the age at which orchopexy has been done and whether the case has been a unilateral or a bilateral one. In cases of unilateral testes, if orchopexy is done within 1 year of age, good fertility is maintained. Almost 85 to 90% cases are fully fertile and the opposite testis is also there. So there is no problem. But in cases of bilateral undescended testes, this rate drops down to around 50 to 60%. Okay, so reasons being decreased number of spermatogonia as well as decreased motility of the sperms as well as dysmorphic or morphological defects in the sperms. These are the causes. But if undescended testes is not brought down by 1 year of age, then by 2 years of age, almost 30% of the patient become totally infertile, and by 3 years of age, almost 78% or 80% patient become infertile in cases of bilateral, and proportionately in cases of unilateral, and even in cases of one-sided undescended testes. If it is not brought down in time, opposite testes also is known to undergo some sort of histopathological changes, probably because of autoimmune reactions. So it is very important that orchiopexy needs to be done by completed by 1 year of age in most of the cases. And
Further, whether it reduces the risk of the testicular malignancy or
no,
not?
orchiopexy do not reduce the risk of malignancy, but advantage it offers that if a testis is brought down and put in the scrotum, then early identification of any changes in the shape, size, or any swelling can be observed and caught early and can be investigated. So bringing the testis down does not alter the malignant potential, but certainly helps in early detection of the malignancy.
So now come to the second case, a 2-year old boy that comes with the complaints of the absence of the normal urethral opening. passing urine from the undersurface of the penis. And local examination, there was a subcoronal ventral urethral meatus, absent ventral prepuce with excess dorsal prepuce and mild chordee. Dr. Geetika, what could be the diagnosis? Why coronal? I just wrote subcoronal. Subcoronal hypospadias with minimal chordee and no undersurface testes. Okay. So, Dr. Anand Pandey, what additional finding you want to see in the local examination of this child?
You to examine the penis as well as both testes. In penile examination, what you can see, there is absence of prepuce on the undersurface. So it is a, remember the term hooded prepuce. It is said hooded prepuce because most of the prepuce is the dorsal aspect. You need to see the penile opening. Hello.
ये देखो.
After that, apart from penis, you need to examine the scrotum. Both testes are present in the scrotum or not, because sometimes in case of intersex, testes may not be palpable. I think this is all for the short examination because it will be given to you as a short case.
So, Dr. Sudhir, what is a chordee and what are the causes of chordee and how will you assess it?
One of the component of hypospadias is ventral curvature of penis. That may be mild, moderate or severe. Common causes of chordee is most of the cases due to skin teething, and some cases due to short urethra, maybe short disproportionate tissue. Chordee should be measured intraoperatively after degloving the penis, that is known as artificial erection test, that is Gitti's test, after applying a tourniquet at the base of penis. And chordee is divided into mild, moderate, severe, measured by a instrument goniometer or some smartphone app is available nowadays. So if chordee is less than 30 degree, that is mild chordee, and 30 to 45 moderate, more than 45 degrees severe chordee.
Yes, rightly mentioned, Doctor. And so, Dr. Ashwin, what is the management of hypospadias and what are the goals for the management?
Well, before describing the management, the goals are a cosmetically straight penis with the meatus at the tip of the penis, okay, and the cosmetically aligned skin. That is the goal of hypospadias repair. Management is very vast. I mean, there are more than 100 techniques described for hypospadias repair, and you can very well imagine that since there is no common consensus that which is the best technique, so it's a very complicated subject. So ultimately, our goal is to make a straight penis. The meatus should be slit-like at the tip of the penis, and skin should be cosmetically around, with or without reconstruction.
Stimulation.
Not fit into these.
What the hormones have to be used. And Dr. Rawat, how will you manage this case, this index case, and what are the other techniques used for the distal hypospadias? I am talking in the reference of the first, what the technique you will use, the index case that I have.
So the picture which you have shown is basically distal penile hypospadias or subcoronal hypospadias, right, with mild chordee, and it seems to be good size of glands. Urethral plate is good, prepucial skin is very good. So we can plan accordingly, and the most probably जो हम लोग commonly we are using is that we can use a tip urethroplasty.
This urethral meatus would have been located at a proximal location, or it is associated with the very severe degree of chordee. Then will you manage?
You just to reassure the parent, see the meatus, and tell them to come back after 6 months.
Okay. So first, most important is that do not.
Plus suture, appropriate suture and magnification should be there.
Okay.
Post-operatively,
Antibiotic prophylaxis.
antibiotic and avoid bladder spasm, laxative should be, constipation should be avoided.
So if anyhow these complications occur, how will you manage these complications like retrocutaneous fistula occur, like meatal stenosis occur?
If in follow-up you should see if there is a meatal stenosis and fistula is there, we can calibrate for meatal stenosis, and not heal, second sort of surgery may require.
So that we do after 6 months.
After
Mostly,
6 months.
mostly small pinpoint fistula usually heal by that 6 months, 6 to 12 months. But after that, and meatal stenosis can be managed with the calibration or dilatation, but not then metoplasty can to be done. Urethral stricture, all these procedures have to be done the redo repair. So now we come to third case. This is a 1-day-old male neonate that who presented with the chief complaint of abscess of normal anal opening, meconiuria. On examination, there is a bifid scrotum, flat perineum, anal dimple is present, and no meconium staining seen anywhere. So, Dr. Priyansh, what can be the diagnosis? Okay. Yeah. High male anal rectal malformation. So, Dr. Anand, can you comment that how these local perineal examination can give clues to the type of anomalies in these baby of ARM?
You see, what we can say, many of these things you may not be needing during our MS examination, because these are mainly for the pediatric surgeons. But as a general surgery student, you need to very simple things. If you are able to see the small opening, because not all anal openings are not patent, there may be a small opening in the perineum, then it is a there is a classification of anal malformation, a very broad one, but you can simply use it as high, intermediate or low. If you are able to see the opening, it is a low type which can be managed by perineal surgery only. And the other thing, if you are able to see a flat buttock, meaning by flat bottom, gluteal muscles are not well developed, this may be a case where you may need to go for a, we can say, 3-stage surgery. I am not here as of now to make the surgical aspects. High type, if you are a flat buttock, and personally I think as a MS surgeon student, you don't need to go into these much of details. If you have an opening, it's a low type. If you don't have an opening, say it's a high type of anal malformation. For an MS, this is more than sufficient. There is a lot of literature which is written here, but practically speaking, for examination, you may not be needing all of it.
So, Dr. Aryan rightly mentioned, but you have to examine first is the meconium, from where meconium, if there is a meconiuria present, okay, or you can see meconium, then it means some urinary fistula is present and anomaly is high or intermediate, okay. If we can see bucket handle at the anal dimple, then it is a low anomaly, and if anomaly, anorectal is already present, cardiac anomaly, you have to auscultate the, and then tracheoesophageal fistula, you have to put the, in the neonate, you have to definitely nasogastric tube to rule out the tracheoesophageal fistula. For renal anomalies, for diagnosing, you have to do the ultrasound of KUB region and limb.
New investigation which is come, this is known as a prone cross table lateral film. This is known as a Namaz position. You examine, and this is somewhere the pubic symphysis. So if you draw a line from this to this is known as a pubic symphysis, a PC line, a pubococcygeal line, and if the rectal pouch is below that, or you can say above this, then this is the high rectal malformation. And below that, and this is the iliac bone, ischial point, sorry. This is the eye point, lowermost point of the this ischial bone, and then it is above that, so this is the intermediate. And if the gas shadow is below that, this is the low type of rectal malformation. So this is the interpretation of this. Sometimes you may get confused when there is a sacral agenesis, right? Then you have to go for identification. In that situation, there is a difficult task for you people. I'm not going detail about that for the MCH. For you people, you just remember PC line and eye point. Okay? This PC line is basically for the pelvic muscle attachment.
So, Dr. Reddy Ravit has sir has rightly mentioned. So one point, sir, probably this X-ray has to be taken at least 18 to 24 hours after birth, not before that.
This is due to the dilatation of rectum should be subside, inflammation and edema should be subside, and after that age, we can well identify the fistula.
Okay, right. So, Dr. Anand Pandit, do you want to do any radiological imaging before doing this definite procedure?
Definitive surgery, a technique which is called as pressure augmented colostogram. this is the word. In that patient, we see the fistulous communication between the genitourinary tract and the gastrointestinal tract, because this gastrointestinal connects with the urinary tract via a small opening. So with the pressure augmented colostogram, when you
Good afternoon, everybody. So we are starting this session of case presentation. Dr. Ayush Pandey from Department of General Surgery. He is JR3 in Department of Surgery at Integral Medical College. He will be presenting this case, and this is a very important topic as far as MS exam is concerned. And we are not here to just pull you up. We want that this is not your MS exam, this is just a preparation for your MS exam. So we want the participation of all the students present here.
Good morning, everyone. Good morning, Mr. Today I'll be presenting a case of 50-year-old male patient named Nanku, resident of Barabanki, farmer by occupation, who came to the hospital with a chief complaint on pain in left leg since last 1 month and blackish discoloration since 15 days.
Blackish discoloration of what part?
Blackish discoloration of the foot since last 15 days. History of presenting illness. The patient was apparently asymptomatic 1 month back when he started experience pain in the left calf region, foot and the toes. Since 1 month, which is sudden onset, gradually sudden onset, progressive in nature, which is dull aching pain at the left leg. Due to pain, the patient sleep was disturbed and was relieved on taking medications. The patient had history of pain in the left foot and left leg, which increased on walking and reduced after 4 to 5 kilometers, but patient didn't pay much attention to it. The patient also had complaints of the discoloration over the left toe, and which was progressively increasing.
All the toes or just a single toe?
On 15 days back, we started with the single toe and gradually it increased, involving all the toes and distally 4 to 5 centimeter distal to the great toe. At present, there is no history of discharge from the site. Since last 7 days, there is also complaint of ulcer present on the dorsum of the foot and ulcer on the anterior tibia present. There is no history of pain, pallor present on exposure to cold, exposure to bluish discoloration on exposure to cold, or redness on exposure to cold. There is no history of chest pain. There is no history of blackout or cardiac complaints. There is no history of abdominal pain. There is no history of tingling sensations.
Here I would like to ask the students also, what is claudication? What? What is the classical presentation of peripheral arterial disease, which I mean to say Berger's disease? What is classical presentation of Berger's disease? जोर से बोलो, खड़े होकर बोलो जोर से. What is intermittent claudication? Anyone? What is intermittent claudication? You are all first year resident or third year? All third year resident. It's a very basic question.
Start complaining of pain.
Then what will happen?
For
what is the grading? इसी के साथ बताओ what is grading?
Boyd classification of intermittent claudication in which patient it will मतलब उसको रेस्ट लेने पे पेन रिलीव हो जा रहा है.
तो रेस्ट वो तो आगे का स्टेज हो गया. ग्रेड पहला ग्रेड क्या है?
The patient will start experiencing pain, but he will still continue to work despite of pain. It's
Yes.
grade 1. In grade 2, the patient will start experience pain, then at rest then after that, when the pain subside, then patient again start walking is grade 2.
Yes. And
Then grade 3, the patient walking around 100 meter, then he started pain. It's a claudication distance.
any चलता क्या है पेन हुआ बट स्टिल ही कैन वॉक
Still he can walk is grade 1. Patient मतलब उसको रेस्ट लेना पड़ेगा जब पेन होगा, then when the pain subside, patient then start continue to walk.
he is compelled to take rest.
Yes sir. Compelled.
So what is the cause of pain in grade 1 and grade 2 and grade 3?
When मतलब when the muscle is on exertion, then there is a release of lactic acid which release finally the P that causes the pain.
So that is muscular pain.
Yes sir.
Yes, muscle ischemia.
Yes sir.
And in grade 3,
Grade 3
anyone? कोई और बताओ?
neurogenic.
Yes. It's the cry of dying nerves.
Yes sir.
So vasa nervorum they are involved. ठीक है चलो आगे बढ़ो.
Plexus around the muscle. Plexus of nerve.
Nervorum.
Plexus of nerve plexus.
It's vessel.
Vessel. Plexus around the blood vessel nerve.
So it is ischemia of nerves. The arterial supply of nerve is चलो आगे बढ़ो.
Past history. There is no history of similar illness in the past. There is no history of hypertension, cardiac disease, type 2 diabetes mellitus, or any collagen disease. Personal history. The history of smoking since last 30 years. One packet of BD per day. The cessation of smoking was done on admission to the hospital. And there is relief of pain after he stopped smoking. His family history is not significant. Treatment history. Patient has been on analgesics since last 1 month, and there is no surgical previous surgical history. Then on examination, patient is thin built. So previous surgery histories can lead to deep vein thrombosis, or it can lead to emboli formation, which can cause thrombus in the patient case. Sir, long bone surgery like femoral bone fracture or infection. On general physical examination, the patient is thin built, moderately nourished. He is well oriented to time, place, and person. Patient has no pallor, no itching, no clubbing or lymphadenopathy on examination. Patient has edema on the left foot, which is described later. Vitals, patient was examined in a well-lit room. The pulse was 76 beats per minute measured in the right radial artery, which is good volume, regular rhythm, no radial or radiofemoral delay. Blood pressure was 130/70 measuring in right arm in supine position. Elasticity. Rate, rhythm, volume, radiofemoral. Its characters are elasticity, pressure. So thickening happens. Thrombophlebitis can be present, which causes thickening. Calcification, sir. Calcification can be present. Hardening of the. Blood pressure was 130/70 measuring in the right arm in supine position. The temperature was A febrile. Partial pressure was 98% in the room air. Systemic examination on respiratory system, bilateral air entry was equal. Cardiovascular H1 H2 are hers. CNS well oriented time place in person. Upper abdomen soft, non-tender, not distended. No lump can be felt. On local examination, patient was sitting on a
Before going on to local examination, you should tell something about your respiratory findings.
So no respiratory finding, there is no obvious abnormal finding, sir. Sir, on local examination, patient is in supine position, lying down. He was holding the his left leg on inspection. Obviously, left lateral. On inspection, there is muscle wasting which is seen in the left thigh, left calf of the patient as compared to the right leg. There is bluish discoloration which is present on the involving the greater toe and the lateral dorsum of the foot. There is ulcer present on the dorsum of the foot, approx size of 5 to 4 centimeter, and there is signs of chronic ischemia. There is loss of hair, there is shining of the skin, and there is loss of subcutaneous tissue, which is visible on the left leg. Temperature difference. Normally filled veins are seen in bilateral lower limb. No discoloration seen after along the vein. No guttering along the course of the vein is seen. The left foot shows signs of peripheral ischemia. Gangrene is there is atrophy which is there is on examination, there is loss of concavity which is seen on the toes. There is brittleness present on the nail, and on palpation, the skin over the left foot is cold as compared to the right foot, and in the left lower proximity. The discoloration, the ulcer is present on the dorsum of the foot, which is 4 to 5 centimeter, and the base of the ulcer is healthy right now. There is no complaints of any discharge, or there is no signs of infections present as such. They, on a palpation for peripheral pulses, the dorsal pedis artery is firstly palpated on the left hand side and then palpated on the right side. Femoral. On palpating on the normal side, on right hand side, femoral, popliteal, anterior tibial, posterior tibial, and dorsal pedis artery can be pulses are normal. And on the left hand side, the pulse cannot be elicited from popliteal to below. Popliteal, anterior tibial, posterior tibial, and dorsal pedis artery could not be palpated. Pulse on the femoral is feeble on palpation. So, and it is on the deep ring, that is anterior superior iliac spine to the pubotubercle below the deep ring. Sir, on the inguinal ligament, that is anterior superior iliac spine से pubotubercle के midway पे 1 centimeter नीचे is the pubotubercle. Superficial ring, sir. Superficial ring. No, sir. It is midway between the ASIs and pubotubercle. Popliteal artery is seen on the after making the patient to lie on the supine position. The knee is flexed in to 130. इसको इसी तरह इसको मोड़ना
slightly flex the knee, वो काम नहीं करता है. हाँ.
So after flexion of the knee, we palpate between the lateral and medial condyle of the tibia, and we examine on the base of it.
Popliteal artery pulsation in this patient. बड़ा पतला सा है, दुबला सा मरीज है, उसमें शायद मिल गई. So the method which he has described is very much correct. Okay, where you look for dorsalis pedal, anterior tibial artery pulsation.
So anterior tibial artery is felt between the both malleolus, the anterior aspect, we palpate,
and dorsalis pedis.
Interdistal. The interdistal
हेड तो बेटा
space.
इधर आएगा ना, हेड इधर आएगा आगे, कहाँ पे? हेड है या बेस है? बेस, ठीक है. और नियर दी navicular bone, ठीक है. And what is that site where
Medial malleolus and maculation. Case summary. 40-year, my patient, 40-year-old Nankur resident of Barabanki and farmer by occupation. He came with the complaints of pain in left leg since 1 month and discoloration is 15 days with ulceration which is present on the dorsum of the foot. On examination has reduced. Sir, the cause, as the patient has complained of the pain was sudden and 1 month back. So it could be a thrombus infarction, sir, which can be present in the femoropopliteal region, which can cause the pain which was sudden. So 50 years old. Sir, in patients less than 40 years old, which are mostly male and chronic smokers, the Budd disease, also known as KOA, is most common. And in patients which are more than 50 years old, with a history of hypertension, with a history of diabetes, are most prone for atherosclerosis and sedentary lifestyle. Sir, sudden history mostly goes for embolus, embolus and critical ischemia, which can be due to atherosclerosis and occlusion. That in this age also, because in Budd disease, the patient has long history of intermittent claudication, and then which progresses to resting pain, then which progresses to gangrene.
What do you think in this patient is the cause of occlusion?
Sir, in this patient, it is a critical limb ischemia patient with thrombus.
What do you mean by critical limb ischemia?
Sir, critical limb ischemia is if chronic ischemia is present, chronic limb ischemia is present in more than 2 weeks. That is critical limb ischemia. Sir. With gangrene, sir. More than 3. Failure. Yes. Critical limb ischemia. Yes, sir. मेजर नहीं किया था Sir, normal is 1 to 1.03. 0.9 to 0.5 is normal. 0.5 to 0.4 is 0.3 is severe, and less than 0.3 is critical. Less than 3 is critical.
Yes.
And more than 1.4 is 0.3. Less than 0.3 is critical, and more than 1.4 is calcification.
It can be acute on chronic ischemia, isn't it?
Yes, sir.
How can you explain that?
Sir, as patient had history of complaints, which was he had intermittent claudication, 4 to 5 kilometers. He used to walk and then has relieving pain, but he dismissed it. And there was sudden onset of the pain for last 1 month. That can be correlated with acute on chronic ischemia. And the patient also has the signs of ischemia, which is loss of skin, loss of appearance tissue, shining, loss of hair.
So, on the basis of your history and examination, what do you think is the level of occlusion?
Sir, on the examination, as we cannot feel the pulses below popliteal, including popliteal and below, and we can feel the pulses, like few pulses of femoral are present on the left hand side. It is mostly femoral popliteal junction can be involved. Sir.
And what is the commonest site most commonest site which is involved in these types of ischemia?
Sir,
Femoroiliac, I think.
femoroiliac site, sir.
So how will you manage this case? What bedside investigation rather you would like to do?
So for bedside investigations, we will do the routine blood investigations, which includes CBC,
वो तो blood investigation वैसे होगा, but
then we go for Doppler scans, Doppler study.
ABPI एक तो तुमने बताया.
ABPI study, Doppler study, and
what is Doppler study?
So Doppler study, in this we see for B mode scan and duplex scan, and accordingly we see for the triphasic or biphasic flow which is present. If the triphasic flow is present, which is present in the normal vessels, and if the flow is reduced, it can go to biphasic, and we can show us the range, the area which is involved, and accordingly we can produce intervene.
So why can't it be deep vein thrombosis?
Sir, because the history of the patient doesn't show any signs of any significant history which goes toward DVT, sir. The patient didn't have any long-term surgery. The patient had no history of bed rest for a long time, sir. No sedentary lifestyle.
What is the classical presentation of deep vein thrombosis?
Sir, in the patient complains of pain in the calf region, and which can be elicited with Homan sign and
so there has to be swelling.
Edema and swelling.
That is not there.
It can also cause dislodgement also. That's observation.
Echocardiography, or is it necessary to perform echocardiography in such patients?
Yes, sir. To look for yes, we have to do echocardiography, and we have to also examine for the other vessels, like we have to take history of blackout or loss of consciousness, or there is history of blurring of vision, or there is abdominal pain. There are other places of claudication.
Nowadays, echocardiography is a bedside investigation. Okay. So I think it should be mentioned in the list of various investigations which are required to evaluate the patient of critical ischemia.
What specific tests you would like to do to find the level of obstruction?
Sir, CT angiography can be done to find the level of obstruction.
Okay. What about
digital?
Any other angiography?
Sir, DSA, sir.
What is that?
Digital subtraction angiography.
How you do angiography? Have you seen? How it is? Anyone can describe the method of doing angiography? That is a technique. You go to femoral. Yes. Anyone can describe? Seldingen techniques. So what is DSA?
Sir, the digital subtraction angiography.
So what do you subtract then?
Ankle pressure. I don't remember, sir. I cannot recall.
Subtraction आप soft tissue जो है bone है muscle है उसको subtract कर देते हैं तो you see only the arterial tree.
CT जहाँ पे होता है तो कंसोल
So Leriche syndrome is present in the patient of if it is the claudication is present or object.
Yes, anyone from the students? What is the significance of Leriche syndrome?
So the blockage is at the level of iliofemoral junction involving a pelvic region.
So what is the presentation? What type of history patient will be? One एक तो कहाँ ही impotence का है sexual impotence, but claudication कहाँ पे होता है?
Pain in the gluteal region. The patient will present with the pain in the gluteal region along with the thyroid and the thigh.
Yes. treatment options?
Sir, we will start the patient according to the medication, according to the investigations. We should start the patient on lipids. We can start the patient on blood thinners. Clopidogrel we can start, sir. Pentoxifylline we will start, which has shown good results. And after doing CT and if we see the level of thrombi which is present, we can go for endovascular intervention, like we can go for ballooning and stent, and for if the gangrene increases, we can go for surgical as well, in which we can go for bypass surgery and as well as amputation for the involved toe.
To remove obstruction because of atherosclerosis, what options you have?
Sir, for to remove the clot, sir, endovascular we can go by ballooning and stenting, which can Dacron stent can be used. And if the segment is involved, like femoral segment is involved, we can go for if iliac segment is involved, we can go for aorto femoral bypass, any bypass.
What graft you will use? What graft you use? Yes. Reverse saphenous, yes. What do you mean by reverse saphenous? जोर से बोले, खड़े होकर. Why?
Well,
any other newer techniques, any newer advancement? Yes. What is subintimal angioplasty? Have you anyone heard about subintimal angioplasty? So it is just like angioplasty which is done in the subintimal vein.
Sir?
See, there is a thrombus inside the heart which has traveled down to say femoral artery. What you would like to do in cardiac system?
Sir, thrombus in defibrillation and the old infarct which are present, sir. During systole it goes, sir. Sir.
Okay, what are other causes of pain in lower limb which can mimic claudication or pain due to peripheral arterial disease? जोर से बोलो. Yes, vasculitis, yes. Yes. Vasculitis, many specific? You mean to say collagen disease? Collagen disease. So collagen में what कैसा presentation होता है?
medical history of temporomandibular joint dislocation.
नहीं, वो तो I don't know, but what is the presentation if it is because of collagen vascular disease? It's bilateral. In fact, all the four limbs have been involved. Any other cause of pain which may mimic claudication of peripheral arterial disease? Frostbite. osteoarthritis of knee हो सकता है. But how will you differentiate clinically and by history and by examination? How will you differentiate between osteoarthritis and pain and this claudication? The pain in osteoarthritis will be from the first step only. एक कदम लेगा पेन शुरू होगा. But in case of claudication of TAD, वो तुरंत नहीं होगा. It will take some time. Yeah.
Relief in posture.
Prolapse intravertebral. Any other questions?
Yes, sir. Sir, first we'll try for medical management. We'll ask the patient. Yes, sir. So we'll wait for the line of. There's a line of demarcation. We'll wait for line of demarcation. Sir, sir, rise. Tennis. Raise amputation. Raise amputation. Sir, tennis amputation. Sir,
Any from this side?
tennis racket. Thank you, sir.
So thank you all the panelists for the case discussion. And I would like to invite Dr. Parag sir and Dr. Geetika ma'am for felicitation of all the panelists. Professor Pankaj Singh, Professor Suren Kumar sir, and Pankaj Singh sir. Now please everyone move for the tendon repair and vascular repair workshop in the RP Shahi Skill Lab.
you.